Hello, everybody. Welcome here. I welcome you. I will be presenting here today to you on the topic of sleep strategies for persons with Huntington's disease. I'm Amir Kuturik, and I'm coming from HD Clinic in Columbia, South Carolina. So before we start, we're just going to go over this generic disclaimer. So for your information that all the information presented here is not intended to be a medical advice and should be taken with common sense, and any points of interest should be discussed further with your practitioner before you do any further action, okay? So as I mentioned, I'm coming from Columbia, South Carolina. When people talk about South Carolina, they frequently think primarily about Charleston or Myrtle Beach maybe, and not everybody knows that Columbia is the capital of South Carolina. And Columbia was intentionally planned and built in the geographical center of the state. So as you can see, it's equidistant for each corner of the state. And it's also very accessible to Augusta, Georgia, for example, or Charlotte, North Carolina. And it's on a good day with the good traffic, it's 3-hour drive from here. So I just arrived today for this presentation, and it was fair traffic, I would say. Central positioning of a clinic within the state like this has some advantages. So we were able actually to establish our clinic fairly early. Our HD clinic was established in 1985 by Dr. Ruth Abramson, who is here with us. And since then, we have been providing almost for 37 years multidisciplinary treatment and care to patients, caregivers, and families with Huntington's disease. And we have been participating in independent studies, collaborative studies, multi-center clinical trials, and also we did some sleep research as well, and probably that's why I'm invited here to talk to you about sleep today. So I will talk to you first a little bit about general facts about sleep, and then we will later on discuss more about sleep in Huntington's disease and strategies how to manage sleep in Huntington's disease. So people have been fascinated with beneficial effects of sleep for millennia, and probably nobody was more poetical about it than William Shakespeare, who referenced to sleep in multiple works of his, and probably the most interesting one is the one from Macbeth, where he states, innocent sleep, sleep that suits all our worries, sleep that puts each day to rest. Sleep that relieves the weary laborer and heals hurt minds. Sleep, the main course in life's feast and the most nourishing. So now you know why I'm a doctor and not an actor, right? So yeah, over the centuries, we were fascinated with sleep. We know we were dreaming. We didn't know what to think about it. We were thinking about some mysterious properties of sleep. We would hear somebody snoring or somebody sleepwalking. So yeah, it was very, very intriguing, but we didn't know much about it until we started using electroencephalography or EEG to study sleep, where we learned that there's lots of activity going on through the sleep, and that we can actually identify several specific patterns that help us define sleep stages. So I'm just going to try not to be too technical, but during wakefulness, there's a background activity on EEG that is called alpha rhythm that has certain frequency, which kind of disappears and goes away during drowsiness. And then when sleep stage 1 occurs, it's defined by occurrence of sharp vertex waves and some sharp transients in the occipital leads. And then sleep stage 2 is manifested by further superimposition of sleep spindles and K complexes, and then sleep stages 3 and 4 are manifested by further superimposition of very high amplitude slow waves that have certain percentages of the recording. And then there's this most fascinating sleep stage called REM sleep, which stands for rapid eye movement sleep, which is manifested by background of low voltage, a faster activity that resembles actually activity of wakefulness. So it's called paradoxical sleep. So this was in 1950s, and then in 1960s, when people started flying to the moon, we started hooking up additional devices with EEG to study sleep. For example, echocardiograms, pulse oximetry, muscle tone monitors, chest movement monitors, airflow monitors, and became with the concept of polysomnography, when we're recording all these things in parallel throughout the night. And we were able to discern two polysomnographic patterns. The one is referred as non-REM sleep, which relates to EEG stages 1 through 4, and it has certain polysomnographic features that are manifested by preservation of muscle tone, preservation of reflexes, slow rolling eye movements, decreased autonomic flow, and increased endocrine activity. So increased production of growth hormone, prolactin, or cortisol. So it plays a significant role in supporting our immune system and growth and development. And there's the slow wave sleep, which corresponds with EEG stages 3 and 4, which is the most important phase of sleep for physical recuperation. So you can sleep all night long in sleep stages 1 and 2 without any interruption, but next day you will be exhausted because you didn't reach any stages 3 and 4. So when we talk about REM sleep, when we study polysomnographic patterns, we will see that we have this rapid alternating eye motions during this sleep, and EEG is similar to wakefulness. So that's why we call it paradoxical or activated sleep. But there is absence of skeletal muscle tone. And that is important because if you're doing REM sleep, you're dreaming. You're experiencing certain events in your subconsciousness, we would say. If your muscle tone was preserved, you would probably be able to act on those dreams. So it's really important that there's absence of muscle tone during this phase of sleep. So during REM sleep, we also have very active autonomic outflow, such as increased pulse rate, blood pressure, blood flow, increased metabolism. And the most fascinating feature of this stage is obviously dreaming. We think that REM sleep has a role in memory consolidation and also in emotional processing. So usually when people go to bed and retire, they usually fall asleep within 5 to 10 minutes. That's quote-unquote normal sleep latency. And then they initially enter non-REM sleep and pass through succession of 4 stages, and then in an hour and a half or so, they enter the initial and first REM period, which lasts about 10 minutes, and then they alternate every hour and a half or so non-REM and REM cycles through the night, in overall 4 or 5 cycles as such. And usually if you don't have alarm clock to wake you up in the morning, your final REM period will merge with your awakening. So if you're on vacation, you frequently kind of have dream waking, like mixing up with your new environment, and you feel like you're in heaven or something, right? All right. So there's, as we talk about sleep, it's also important to mention sleep-wake cycle, which is one of basic circadian rhythms in the nature overall. In humans, sleep-wake cycle is diurnal, with people being awake during the day and sleeping during the night. Most of people sleep 6 to 8 hours through the night, from between 9 p.m. and 9 a.m. Most of people still retain this afternoon nap time around 2 p.m. So if you fall asleep during this lecture, it's not because you have sleep disorder, because there's actually natural variation. Okay. And this circadian rhythm is actually controlled by the suprachiasmatic nuclei in hypothalamus, and there's also additional contribution of pineal gland that secretes a hormone called melatonin. And I will talk about melatonin later because it has a very specific role in Huntington's disease that we will address. So our cyclic periodicity in humans is just about 24 hours. So as we age, sleep also evolves through our life, right? So neonates sleep up to 20 hours per day, and 50% of sleep is that fascinating REM sleep. Right? I guess new oncomers to the Earth have to learn like gravitational field of Earth, they have to learn like oxygen saturation in the atmosphere and that kind of stuff. So they have lots of processing that they do in REM sleep, right? So as we age then, in adults, usually people sleep 6 to 8 hours, and only 25% of sleep is in REM sleep. So in elderly, however, we have probably the same amount of sleep, and it's not changed from adulthood. However, sleep becomes more fragmented with multiple awakenings at night and multiple naps through the day, shorter REM periods, and less time spent in REM sleep. So to kind of paraphrase now what we already learned from William Shakespeare earlier, there are multiple beneficial effects of sleep, right? So we know that the sleep definitely helps us with conservation of energy. It's instrumental in body growth and development. It is important in restoration of our neurological functioning. Also resets our mood, behavior, and affect. It's important in memory processing, also enhances our cognitive function, it's important in physical recuperation, supports our endocrine function, and enhances our productivity. But it's not only human nature to sleep. Any creature on this planet that has any nerve cells potentially has periods of sleep. So just recently we learned that even jellyfish with very primitive nervous system with few neurons has very similar patterns of sleep. So I just want to now turn towards Huntington's disease and what we learned about sleep in Huntington's disease. So sleep research in Huntington's has been very sparse, and studies in humans are done sporadically. And when I was reviewing literature for this presentation, they significantly declined since 2015. We have significant decline in any studies with humans with Huntington's disease. So, prior studies that were done, they had various designs. Some of them are using polysomnography, some of them are using EEG, some of them are like using actigraphic recordings, just questionnaires, imaging, or so on. So frequently they will have low number of participants and be usually done in individual centers rather than multi-center trials and so on. So outcomes of those studies are frequently variable and sometimes even contradicting. Currently, most of the studies that are ongoing pertaining to sleep in Huntington's disease are done on animal models such as fruit fly, which I don't know how much that correlates to humans, then mice and sheep. But we have this meta-analytic techniques that we can use. I think they were actually most helpful to us to generalize some knowledge about sleep in Huntington's disease. So meta-analysis is a statistical method that combines the results of multiple prior studies on the same subject. So, for example, sleep in Huntington's disease. And those meta-analyses are able to extrapolate common results that have some general implications. And I think I use that mostly for this presentation. So none of those things that I'm presenting come from one single study or something. I was trying to get meta-analytic analysis of most of those prior studies. So definitely there is more strategic and a systematized approach needed in sleep research in Huntington's disease. Particularly because we spend 30% of our life in sleep. So I would say if we spend 30% of life at work, 30% of life with our family, and 30% of life in sleep. So I think we are really neglectful towards sleep. So what would happen if there will be no research in work or business, no research in family, really? How that would repercute to our life, right? But we really don't care because we sleep 30% of the time. Well, research is sleep. We don't do anything. We just sleep, right? But lots of people die in sleep, right? 30% of people die in sleep. So it's really important to go ahead and evolve further into sleep research. So I just want to also mention some definition of the terms that I'll be using here in this speech. When I talk about sleep abnormality, I'm talking about the deviation from normal sleep patterns that were noted on EEG and polysomnography, right? But the significance of those kind of deviations are uncertain, right? We just know that it's a variation away from normal. Also, when I talk about sleep disturbance, I'm talking about the deviation from a normal sleep pattern noted by patient or caregiver that also doesn't have any specific significance. However, when I'm talking about sleep disorder, I'm talking actually about the disturbance that represents a problem to patient or caregiver. So this is the important distinction: sleep disturbance and sleep disorder. Sleep disturbance can be anything that interferes with our sleep, but it doesn't bothers us. It's not disorder. But even minor change in sleep that is problematic to us, that becomes a disorder. So just about 90% of HD patients report some sleep disturbances, and in half of them, they represent a problem. So in those that represent a problem, they do affect physical and mental well-being of patients or caregivers. And most frequent ones are insomnia and frequent nocturnal awakenings, daytime sleepiness, or called hypersomnolence, sleep-wake cycle abnormalities, are very prominent in Huntington's disease, and abnormal motor activity during sleep. Those are the most cited throughout the papers that have been published in the past. So insomnia is a disorder that affects initiation and maintaining sleep. So it results in impaired duration, depth, and restorative properties of sleep. And maybe result from heightened physiological arousal, but also it results in decreased amount of slow wave sleep, decreased amount of deep sleep. So this restorative property of sleep is lost. So that's why it becomes disorder. If you cannot fall asleep and doesn't affect your life and doesn't make you tired, it's not disorder, it's just disturbance. But if you're tired because you cannot sleep, then it's disorder. Same thing with hypersomnia. So hypersomnia is actually manifested by excessive somnolence or daytime sleepiness, fatigue, tiredness that is related to sleep pattern itself, with frequent naps and sometimes sleep attacks that intrude in a awake state that you cannot really fight off. So this disorder of sleep and wake cycles are very important in Huntington's disease, and there are different types of sleep-wake cycle disorders. So we have delayed sleep phase syndrome, where individuals usually go to bed around 3 o'clock in the morning and they wake up around noontime or in the afternoon the next day. This would be your normal teenager, but it would be okay if it's not bothering you. But if it interferes with your lifestyle and it affects your well-being, then it's a disorder. So we have advanced sleep phase syndrome, when people go to bed at 7 o'clock in the evening and wake up at 3 o'clock in the morning. So that is rarely disorder. It's frequent disturbance, because for working people, going early to bed and waking up early might be actually advantageous, right? But for some people, it might be a disorder. There's also reversal sleep-wake cycle, when people sleep during the day and they're up and active during the night. And there's also sleep-wake cycle fragmentation and disintegration. This is the irregular sleep pattern with random sleep periods, with sleep attacks, and it's most challenging to manage. So, abnormal motor activity in sleep is a very interesting topic in Huntington's disease. HD patients are mostly unaware of movements in sleep, so we usually will learn more about it if we talk to bedmate or caregiver. Sometimes people do think that they have movements of sleep, or they have chorea. They think that they have chorea, but it's consensus in research community that chorea goes away in sleep. So, however, actigraphic studies show that there is increased motor activity during sleep in Huntington's disease compared to other populations. So some people not sure if those movements at night in Huntington's disease are a result of awakenings, so individual awakes and then starts moving, or the movements cause awakenings. So we believe that routine polysomnographs, the way they are done, might not be sensitive enough to discern which one it is. Is that awakening first and then movement next, or is movement first and awakening next? So it definitely will need further fine-tuning of the research analysis there. But definitely lots of individuals with Huntington's disease can experience cramps, and especially with dystonia, and sometimes twitches. Twitches are similar to chorea, but it is not chorea, it's actually myoclonus. It's a multifocal twitch of the muscle rather than a central activity that goes with chorea. And there's also uncertain relationship between Huntington's disease and restless leg syndrome or periodic limb movement disorder of sleep. So in 40 to 50% of individuals, polysomnographic recordings in Huntington's disease show some evidence of restless leg, actually periodic limb movement disorder. But lots of researchers think that this might be the same problem with the polysomnographic scoring. How do you score these movements compared to this? So this periodic limb movement disorder might be actually presentation of Huntington's disease in a different scoring model. So this is also to be settled with future research. There is a sleep behavior disorder that can be mistaken for movement disorder. Okay, during sleep. This is called REM sleep behavior disorder. This is a fairly rare disorder, and it's actually much more common in Parkinson's disease. Up to 30% people with Parkinson's disease can have it. But it's also reported in up to 12% of Huntington's disease patients. But it's not related to the severity or stage of Huntington's disease. And it actually can be precipitated by some type of antidepressants and some type of blood pressure medication that patients might be taking. And it occurs only exclusively during REM sleep, where polysonogram shows augmented muscle tone. So we have this REM sleep with active muscles, which I mentioned earlier. It's important to have relaxed muscle during dreaming, right? Here we have situation when muscles are still active during REM sleep. And then what happens, patients start acting out their dreams, right? If they are running from a lion, they might stand up from the bed and start running around the room and fall over or something like that. If they're dreaming that they're fighting an enemy, they might start fighting with their bedmate or something like that. But most frequently, there are attacks of vigorous physical motor activity, sometimes associated with shouting, and sometimes definitely can result in injury to self or a bedmate in the process. So safety and fall precautions are essential in this REM behavior sleep disorder, and it should not be mistaken for chorea. It doesn't have to have all the features. It can be a very mild case. For example, we just have like maybe talking or moving around. So it should not be mistaken for movement disorder, because it can have significant potential for injury or fall. There is, fortunately, very effective treatment, which is a very low dose of Klonopin, but overall benzodiazepines are not really recommended to be started as a first-line treatment in sleep disorders. So there's another there's another approach that can actually be more suitable for Huntington's disease, which is trial with a regular dose of melatonin. There's also some like cholinesterase inhibitors that can be helpful as well, so rivastigmine. And potentially it would be interesting and would be intuitive to try maybe muscle relaxant, but we don't have those kind of studies on, because it's very rare disorder, and studies are very rare in sleep altogether, let alone Huntington's disease. So this is something that is fairly interesting and will need to be researched further. So overall, sleep disorders can affect life with individuals with Huntington's disease in multiple ways. Obviously, they can result in decrease of mental alertness, worsen irritability, anxiety, even worsening depression, causes attention disturbances, cognitive impairment, slowing of responses, reduced ability for logical thinking, general fatigue. So this is a tremendous amount of effect that they have. And actually, some studies show that HD carriers with sleep disorders may have worse neuropsychiatric outcomes than HD patients without sleep disorders. So they would be a significant incentive to treat sleep disorders early. So, as Huntington's disease is a fairly complex disorder, there are multiple factors related to Huntington's disease that actually may influence or modulate sleep disorders as well. So, many medications that are prescribed in Huntington's disease can affect and modulate sleep disorders. Also, depression and other mental disorders that can occur in Huntington's disease can affect sleep as well. And also, there's again this influence of age, but also sleep disorders correlate with the duration and severity of Huntington's disease. To the contrary, like body weight or body mass index does not correlate significantly. It's fairly inconclusive. And number of CAG repeats does not correlate at all with development sleep disorders. So, talking about drugs that are used in Huntington's disease that can cause sleep changes, we can talk about medications that cause sleepiness. Those are the all familiar ones, like benzodiazepines or clonazepam, different type of neuroleptics, antidepressants. There are also medications that cause activation, stimulation, or sleeplessness, such as amantadine that's prescribed for movement disorder, right? Valproic acid is prescribed for mood stabilization or seizures, and levodopa also that's prescribed for movements or rigidity. So potentially there is a way for strategy to apply to prescribe stimulating medications primarily in the morning and medication that can cause sedation in the evening. Behavioral disorders in Huntington's disease definitely can affect sleep, and depression occurs in more than 30% of HD patients. So sleep disorders are more common in HD patients who have depression. And treatment of depression can improve sleep, and vice versa. Treatment of sleep can actually improve depression. So depression-related sleep disorder can mimic actually sleep disorder in Huntington's disease because it has very similar features like delayed sleep onset, multiple awakenings, early morning awakening, and so. So it would only polysomnographically probably you can discern which one is which is related more to depression or which one to Huntington's disease. As opposed to Huntington's disease, depression has early REM onset and has increased increased period of time spent in REM sleep compared to Huntington's disease. There are also other behavioral disorders that can affect sleep, and for example, anxiety is fairly more than 50% with HD have anxiety, which can also contribute to sleep disorders, and mania, which is not as common, can result in complete absence of sleep for weeks or months. As we age and as symptoms of Huntington's disease start to appear in early stages of Huntington's disease, and sometimes even before any onset of motor symptoms, there may be some sleep changes that can occur, such as difficulty falling asleep, difficulty maintaining sleep, reduce a deep sleep or that slow wave sleep that causes physical exhaustion, or reduced duration of REM sleep, which might cause issues with memory and emotional disturbances, right? So this can occur even before motor symptoms start occurring. And then as we have advancement to moderately advanced Huntington's disease, we have even shorter total sleep time, more difficulty maintaining sleep, increased nocturnal awakenings, further reduction of deep sleep or slow wave sleep, disruption of sleep-wake cycle start to occur. There's more daytime sleepiness, and delayed REM latency and reduced REM duration. And then in advanced Huntington's disease, we have this fragmentation and sometimes total disintegration of sleep-wake cycle, which may become dominant feature of sleep disorder in advanced Huntington's disease. Then we can also have long periods of wakefulness at night. People sleep during the day. Virtual absence of deep sleep causing chronic fatigue that is extreme. So an extreme daytime sleepiness, even sleep attacks that intrude in a wake state. There is also further reduction and fragmentation of REM sleep, definitely more present jerking or twitching of the extremities, sometimes very painful spasms that interfere furthermore with sleep. So for management of sleep disorder in Huntington's disease, we start with general recommendations. when we try to manage so we would like to treat conditions that can contribute to sleep disturbances in Huntington's disease. So, for example, we want to treat comorbid medical conditions, for example, thyroid disorder or diabetes or hypertension or something like that. We want to treat psychiatric symptoms such as depression or anxiety, as I mentioned earlier, especially pain like back pain or peripheral neuropathy. And as well as substance use, right? If somebody is a smoker, it might interfere with sleep, or drinking alcohol on a regular basis, or doing any of like a pain medicine or something like that. So, so it would be again also important to assess the medications that one is taking and prescribe the medications that are causing activation and alertness in the morning, and the ones that are more sedating in the evening again. So when we're considering medications, our recommendations are not based on outcomes of clinical trials in IHD. We have not had any standardized studies testing medications in Huntington's disease that had any beneficial outcomes. So unfortunately, we have to base our recommendation on expert consensus, right? But that's still something, right? So generally, the most recent update is that melatonin is recommended for sleep-wake cycle disorders. Some sedating antidepressants and sedating neuroleptics, such as antidepressants like mirtazapine or trazodone, and neuroleptics such as olanzapine or quetiapine, can be prescribed for insomnia. Clomipramine may be used when there are also associated obsessive-compulsive disorder syndromes. Overall, use of benzodiazepine is discouraged in ambulatory individuals with fine print unless all other measures fail. All right, so we'll touch base about it a little bit later. There is also some additional consideration that I like to put on the table. They are not specifically tested in Huntington's disease, but have been evaluated in general population, especially in elderly population and individuals with neurodegenerative disorders. So chronotherapy is a non-medical approach to treatment of a delayed sleep phase onset. Remember, the individual who goes to bed at 3 and wakes up afternoon next day, right? So the chronotherapy consists of that every day try to push their sleep time by 2 hours. Like the first day they usually go at 3 o'clock in the morning. Next day you tell them go to bed at 5 o'clock. And then next day go to bed at 7 o'clock in the morning. And they push every 2 hours until you push it to 9 or 10 o'clock p.m. where you want to have them. And then you let them go for their own issue stick. It's fairly effective, but it's obviously cumbersome and not very practical, if you can imagine, right? So there's another approach in the same disorder where wearing blocking glasses, such as amber glasses or blue blocking glasses that block certain wavelength of light, 3 hours prior to bedtime may be also helpful in delayed sleep phase syndrome. Bright light therapy may be helpful in advanced sleep phase syndrome and also in irregular sleep-wake cycle syndrome. And so this would be exposure to bright light 3 to several hours prior to usual time of sleep. It will then push it further on to like 9 or 10 p.m. And actually, there are interesting studies in elderly population and people with neurodegenerative disorder. Actually, most of the patients and caregivers prefer this treatment to any other medication prescribed. The effects are mild to moderate, but they liked it because there's no adverse effects. All these things that I mentioned, there's no adverse effects to that compared to any medications, right? So that is something to consider. Other thing that I want to always put on table when we talk about sleep disorders and Huntington's disease is that fall precautions are essential with all sleep disorders and Huntington's disease, right? Because if somebody pages me in the middle of the night and I wake up and try to get my phone, I fall 3 times myself, let alone my patient, right, if they wake up in the middle of it. So it's important that fall precautions are implemented, and we'll talk about it a little bit later as well. Then I already mentioned that it's essential to ensure personal safety in individuals who suffer from REM sleep behavior disorder, right? So in South Carolina, I have to advise them, you know that handgun that you have under your pillow, move it away. right? That's number one, right? So those kind of things, you want to be sure that you take personal safety into consideration in anybody, and you have to have a really high level of suspicion for REM behavior sleep disorder for that particular reason. Also, just want to mention, although melatonin is recommended for sleep disorder by expert panels and so on, it's still being evaluated. It's still not have been confirmed in any clinical trials thus far, and its effectiveness nor safety has been evaluated yet. But melatonin does have significant role and very specific place in Huntington's disease. So some studies have shown that HD patients have lower levels of melatonin in their blood than general population and have more variation in timing of the melatonin production, right? And in some animal studies, regulation of sleep-wake cycles resulted in a reduced cognitive decline. And then some other studies on humans actually showed that melatonin and its receptors agonists, some other medications, may improve not only quality of sleep in Huntington's, but also enhance neuroprotection in Huntington's disease. But those are very limited and very small studies, so we cannot take that for granted at this point. And also it's important to know that in US, melatonin is considered dietary supplement. So by that virtue, it's not stringently controlled in terms of quality of the product that you are buying, and also is not stringently monitored for adverse effects. There's no reporting on adverse effects as much as it is with medications, because nobody takes responsibility to report adverse effects. When you have FDA-approved medication, the company that is marketing that medication has to report adverse effects, and pharmacies have to report any adverse effect reported to them. So it's interesting that in 2015, guidelines of the American Academy of Sleep Medicine recommended against melatonin use by people with dementia. As in older people, it may result in longer activity and may cause daytime drowsiness. So this does not pertain to HD patients, but it is something that is a general now a recommendation from people that specialize in sleep. But help is on the way. So this is the only clinical trial currently ongoing on sleep in Huntington's disease, and rightfully so is addressing melatonin for Huntington's disease gene carriers with HD-related sleep disturbances. However, again, this is a pilot study. What this pilot study means? They are just testing the feasibility of performing this type of study, and probably in the process they will be looking into safety profile as well and outcomes as well. And we will be looking also outcomes in terms of change in sleep quality by certain parameters. And also, I'm glad that it's going to be completed within the next couple of weeks, and we're looking forward to hear about it. And everybody can kind of tune up and follow up on this study within the next month or so to see did it finish with success, and later on hear about the outcomes of the study. So there are also some other potential drugs in the future that we should consider in HD. These are FDA-approved drugs for general population, and they actually has shown some benefit in elderly people in some studies. Okay, but we don't have practically no experience with them in HD. So there are two medications that are actually melatonin receptor agonists. This is Ramelteon and Tasimelteon. And they are prescribed for sleep-wake cycle disorders, right? Like melatonin, but they're FDA approved, which means there's more strict regulation in terms of monitoring of adverse effects and production of the compounds, right? The other two, like suvorexant and lemborexant, are dual orexin receptors, which are FDA approved for chronic insomnia. All right. They also showed good effects in elderly, right? But we don't have much experience at all about it in Huntington's disease. Now, they're FDA approved, so as I said, they have much better regulation in terms of quality and adverse effect monitoring, but it comes with a price tag that is just about $400 per month, each of them probably. No, okay, so most of medical insurance is covered a significant portion of it, but it ends up like monthly copay usually between $60 and $75, which is still multiple times higher than melatonin, which is about $5 per month, right? Yeah. But $65 for something that's safer and better regular might be worthwhile, right? So let's keep looking, and hopefully we'll be seeing some. Maybe this melatonin study that we're talking. Well, we'll learn how to do it with melatonin. Maybe we'll learn if it's better than on the other medication, or can we maybe use some other ones in the same type of research, right? So it's going to be something coming, I hope, soon. All right. So, of course, benzodiazepines are not recommended routinely for treatment of insomnias and sleep disorders in Huntington's disease. But there's that fine print, unless all other options fail. And working with Huntington's disease for 20 years now, I can tell you that there are lots of people that nothing works for their sleep. And then you have to start thinking about some of these medications. So there are, fortunately, several of those benzodiazepines that are FDA approved for chronic insomnia in general population, right? In Huntington's disease, we would prefer rapidly acting medication with very short half-life. They will not have significant hangover effects. However, there is a significant, very specific high risk associated in Huntington's disease for falls and injuries with using those medications, right? And there's the other black box warning that applies to everybody, and I think HD patients in particular are sensitive to all of those things, like risk of physical dependence, withdrawal reactions, abuse and addiction, and also taking benzodiazepine, some pain medication can result in respiratory arrest, sometimes coma, even death, right? So it should be very restricted use of benzodiazepine. We have another class of medication that I haven't seen yet being addressed in expert panels. This non-benzodiazepine GABA receptor agonists. These are so-called Z drugs for insomnia. They are FDA approved for general population for chronic treatment of chronic insomnia, and they're called Zalpion, Zolpidem, Exazopiclone, right? Compared to benzodiazepine medication, they have much shorter half-life once it's ingested, so it goes out of the system relatively fast. But there's, again, this very kind of concerning black box warning just put out like a few years back, stating that there are observed rare but serious injuries related to sleepwalking, sleep driving, and other complex behaviors like automatic behaviors. So people would go and take medications while sleeping, or they would prepare meals and there would be fires. They're fatal. There's some catastrophic outcomes with it. So it's really important to keep this in mind. And the other thing is also, they also control substances class 4, which potential for misuse, abuse, dependence, or withdrawal. So when I would consider this medication, the same limitations that you would apply to benzodiazepine. So when I'm talking about this medication, benzodiazepine, I would use them in extreme circumstances. I would use it in only exceptional cases for short period of time, maybe a week, or only as per needed basis, but less than once or twice per week, probably. And I would use it in specific situation. For example, if you can achieve something in a short period of time, or if there's an acute situation, for example, somebody travels in a different time zone and then goes out of control in terms of sleep, cannot sleep, or changes bed, or goes to a different town, or being admitted to the hospital and then suddenly cannot sleep. I would use those medications more so if there is a supervised environment, so supervised conditions, like nursing home, if they can, okay, we're going to give them that for 1 week, but we can have one-on-one observation for fall precaution and stuff like that. So I would consider that only in very, very restricted circumstances when nothing else helped, and just to transient measure until we establish other treatments that potentially can result in improvement. So it's very important to keep open communication with your doctor when you're talking about your sleep. So there many medications that we prescribe in Huntington's disease can cause sleep disturbances. And you are the one who decides if this disturbance is your disorder, right? So you want to ask your doctor if the medication that you are taking can lead to your sleep issues or sleep disorder. And also you want to let your doctor know how medication affects your sleep. Because you are in charge. You're deciding if that sleep disturbance is disorder, right? So they say, oh yeah, it doesn't do this in general population, but yeah, to me it is a problem, right? So to me it is disorder, right? So, but you should not take any action unilateral. You should always work together with the doctor, because as I said before, they can switch the schedule around, maybe reduce the dose, or move it, prescribe sedating medication in the morning and more activating medication in the evening, right? So also, sometimes doctor can prescribe some medication to help you with sleep, and as I mentioned earlier, some can be just short-term period, right, in certain situation, and you can maybe sometimes anticipate those kind of situation. You want to have some kind of handle. If you're going, you know they're going to travel from South Carolina to California, you're going like 3 different time zones. You can anticipate problem, and you can talk to doctor. How about having something just in case if we're in a hotel and we have a problem, or so this is something you want to maybe potentially plan, right? And sometimes even prescribing a short-term therapy for sleep might have lasting outcomes without further continuation of the medication in the future. So there are other things you can discuss as well. So sleep hygiene is probably the most important factor in long-term regulation of sleep. Not only Huntington's, everywhere, right? So there are multiple interventions that have been always mentioned. So I'll just go through them, and I'll just have a few specifics for Huntington's disease. So during day, we should try to avoid any naps during day. If you start feeling sleepy, you try to change the activity you're doing. Try to do something different. Go for a walk, take a shower, do a chore. Exercise, go play, I don't know, basketball or something else. Try to stay awake. If you must have a nap, just try to limit it to 30-40 minutes. And then you set your alarm clock to wake you up in 30-40 minutes. So you don't oversleep and then mess up your nighttime sleep. So then you mess up the sleep-wake cycle that I talked about, right? And then if you can schedule it, you might want to schedule around 2 p.m. I mentioned this 2 p.m. window, like this lecture is around 2 p.m., right? You want to schedule it during this time. So if you want to schedule this lecture that is at 2 p.m. and then take 30 minutes of sleep, because it should not affect your sleep cycle as much if you take nap at 8 p.m., for example, right? So you want to set your bedtime a specific hour and go to bed at this particular time plus minus 30 minutes. And at the same time, you want to set up your wake-up time and set it on your alarm clock. And then you also want to establish your bedtime routines. For example, turn off TV, your computer, cell phone, brush your teeth, use a bathroom, read a book for a few minutes. And you want to keep with the same schedule even on the weekends, even on holidays. So you want to keep your schedule and routines always the same. Then your sleeping time should start at your chosen bedtime, right? If you don't fall asleep right away or for a while, you should not just keep rolling over your wake-up time to catch up. You just want to wake up at your pre-scheduled time and wake up when an alarm clock goes off, even if you are tired. You may end up being sleepy the next day, but the next night you will have much better sleep, and then your sleep pattern, sleep-wake cycle will not be disturbed further on. In case if you don't fall asleep, you go to bed, retire, and you don't fall asleep for half an hour or so, then you can try getting up and going into another room. You sit in not too bright light, in dim light, sit quietly, maybe read something, listen to calm music, have a sip of water, take a light snack, and do some quiet activity like crossword puzzle. Or if you're obsessing about something that you need to do tomorrow or something that might happen, you can just try the to-do list, just briefly write it down so you don't have to obsess about it. And that really works good for me. When I cannot fall asleep, what I have to do, I just write it down, and then in the morning I forget about my list altogether, right? But it helps me fall asleep. That's most important, right? So do not use your computer, cell phone, and do not watch TV, all right? Do not work, and do not do anything productive, and don't try to study, okay? And after 20 minutes or so, try to go to bed and try to fall asleep. So it's also important to set up your bed in your room, right? So your bed should be comfortable, and you should use season-appropriate coverings. You should use extra pillows, plenty of them, for optimal positioning and support, right? And too hard or too soft of the bed is not very conducive to good sleep, so you have to find your perfect mattress. Bed should be used only for sleep-related activities and some reading occasionally, right? But no work-related reading, no television, no computers, no cell phone. Lowering bed may prevent injuries and falls in Huntington's disease. So we learned that from nursing homes and some support group input, that sometimes even people that have tendency to fall out of bed, putting rails on the bed is a bad idea. It's better to just put a mattress on the ground and some padding around it to prevent falls and injuries. So your bedroom should be cool, not too cold, just cool, well ventilated, and as dark as possible. So in Huntington's disease, I do encourage people to have night lights for visual orientation. They wake up and walk around the room to prevent fall or injuries, right? And the room should be as quiet as possible. And if it's impossible to eliminate external noise, you might try to use some white noise to kind of mask it up. And there are lots of actually apps on cell phone that you can kind of download and have it anywhere you go. If you're in a hotel or something like that, you put it on and you have a whooshing sound that helps you fall asleep. Also, removing unnecessary furniture, little tablets or I don't know, around the room, together with appropriate floor covering or even padding, might prevent falls or injuries, right? So in combination with putting just mattress on that kind of padding of flooring might really reduce injuries from falls significantly. Again, food and drink schedule. So no coffee more than 4 hours after you wake up, right? So if you wake up at 8 o'clock, if this is your wake-up time, you wake up at 8 o'clock, you should not be drinking coffee like myself. I did like 1 hour before this lecture, afternoon, right? You should just, no coffee past noontime, okay? There's no alcohol 2-3 hours before bedtime. So if you go to bed at 11, you should not party past 8. And try to eat your last full meal just about 4 hours before your bedtime, right? You can have a light snack within an hour or so, but try to avoid anything spicy, okay, or too acidic. Especially if you have any hint of reflux, right? You don't want to do any spicy stuff. Just something like dairy products if you tolerate, or honey, or something very light. And not too much, right? Just a little bit. Of course, I don't know what to tell you about smoking or chewing tobacco. I would kind of recommend you just stop it. But you want to do it with your doctor, okay, in a structured way. You should, but at least you should not be smoking or chewing tobacco 2 hours prior to bedtime. If you try to stop smoking, it might actually cause you to be more alert for a while until you kind of kick away that habit. Nowhere in the literature I could find anything written about caregiver sleep in Huntington's disease. All right. So I wanted to do personal effort to learn more about caregiver sleep. And I can tell you that I learned that caregivers' burnout from patient sleep issues is the most frequently cited reason for placement of geriatric patients in institutions. Wow. And probably it's the same in Huntington's disease, what I kind of gather from my experience. So it's interesting that we have no reference on anything of that. So I had to tap into what we learned from our support groups and also what Veterans Administration have researched about shift workers, right? So for caregivers, it would be important to keep and address patient sleep-wake issues as early as possible rather than late. Once it's advanced sleep-wake cycle disorder, it's very hard to put it back. You know, we talked about chronotherapy. How difficult is that to execute, for example, right? Then you want to try to synchronize your sleep and activities with the patient. And for two reasons. For example, you don't want to, okay, now he's sleeping, I'm going to do chores around the house, and then he wakes up, let's go to bed, and he wakes up, and you trying to sleep and cannot sleep, right? And then it's reversed next day again, right? So for that reason, you want to synchronize your activities with the patient and sleep with the patient. And there's another benefit, because when you synchronize your activities with their activities, you can better supervise their sleep hygiene, right? You can better supervise it. Oh, you're falling asleep. Go do now. I don't know, do some chore, or try to pray, do exercise, right? Or now is the bedtime. Let's set a time we're gonna bed. We'll lay down. If you don't fall asleep, go to the room, do crossword puzzles, and go back. So you might also sleep in a separate bed. I found somebody recommending, well, we could sleep in a different room. Well, that's really not feasible for most people. If you sleep in a different room, lots of things can happen, right? So sleeping in a separate bed is much more practical, I would say. And if needed, you can probably arrange some respite time to schedule yourself a block of time for 1.5 hours of sleep around 2 p.m. I like this 2 p.m. because it's kind of physiological, right? And you want to have 1.5 hours so you can have full cycle of sleep with included slow wave sleep, right? You will have to 1, 2, 3, 4, so it will give you physical recuperation, right? And you can try to work with your relatives, or home health agencies can provide physical therapists to come for an hour or so, and you take a snooze at that time. Or you can get home health assistance, and then during that time you schedule it, right? So you don't want to schedule it like at 8 o'clock and then you cannot sleep at night, right? So I think 2 o'clock is just about the right time to do that. And there's no too much science about it. And as I say, this is not medical advice. This is a disclaimer. Already we covered it, right? So just talk to your doctor, see what works for you, right? So when needed, and if possible, you can arrange for night shift caregiver rotations, right? And this is feasible only when you have 2 or more caregivers that are available, right? You have 3 or 4 family members that are to live together, and they can kind of rotate for night shifts, right? So, but it's better to rotate night shifts schedule on monthly basis rather than on daily basis or weekly basis. Because if you, okay, I'm going to be today at night, and you be tomorrow at night, and then every 3 days, so it takes you, when you stay awake one night, it takes you 2 or 3 days just to come back to normal. So if you keep doing this every 3rd or 4th night, it starts being really exhausting. But if you switch it monthly, you're kind of off for a couple of days, but then rest of the month you're doing okay. And then you go switch back to normal, you again for a couple of days, a little bit off, but then you catch up. So it's much healthier for you. And also forward rotation, when you're going to that shift, it's better to do it from being alert, awake, than sleeping to the moment that you go for the first few days, right? So it's better just kind of go and take and then you catch up with the rhythm. And you want to restrict shifts not more than 12 hours for the night shift, and allow at least 12 hours for caregiver to rest after the shift. So that night shift conflicts with regular sleep cycle of the environment for the most part. If you work at night, it's on odds with everybody else. So you want to adjust your lifestyle during a period of that month, and then keep the same rhythm through the weekends and holidays, right? So you would not have it would be better for your health to do it that way, right? All right, so I think that is pretty much what we talked. We talked a little bit about like general sleep issues, and then we talked more about Huntington's disease, and we talked about disorders in Huntington's disease with sleep and potential treatments, medications, and non-medication approaches, and also sleep hygiene. So if you happen to go to Columbia, South Carolina, and you cannot fall asleep, there's the number you can call, and we're going to have we have a sleep emergency crew that comes up to your place and makes you fall asleep right away. All right. All right. And Okay, so these are the references that I used in preparation of this. Again, it's important that none of this should be taken as medical advice, and it should be taken with common sense, and you should apply it to yourself and discuss with your doctor before taking any further action, okay?
Yes.
All right. Thank you very much. And I'll be happy to take any question. They told me there's some kind of app, and let me see if I can get to it. All right. So yeah, there's one good actually note here. They say the air cleaner can produce low white noise and cleaner air. So that's a good approach. I'll take this one on my next presentation. Thank you very much. So taking naps after lunch helps if it does not interfere with sleep at night. I would say, yes, some people have that 2 p.m. Nap time. And if you tend to have problems with sleep cycle, then you want to restrict it to 30, 40 minutes, as I mentioned. Because you don't want to get this like slow wave sleep and get too recuperated so you have lots of energy at night when you're supposed to go to bed. So even if you take a nap after lunch, try to limit it to 40 minutes. Only caregivers that are taking respite can take 1.5 hours. We are clear about that, right? What do you recommend for HD patients who wake up with anxiety and mania? So this is a complex issue, right? We talk about that behavioral disorders can affect sleep. So I think it will be very important to treat depression and anxiety in collaboration with psychiatrists in a gradual approach. Try to see what is worse, depression or anxiety. So if depression is worse, then address that first, and then anxiety is predominant, and then gradually try to sort it out.
Can I make a thought?
Go ahead.
And if there's a family history of anxiety or depression, then maybe there's a medication that has worked for another family member, and that might be something you could talk to your doctor about, and might be a reasonable first approach.
All right. Go ahead.
Coffee. 4 cups of coffee per day will improve your longevity and reduce your cancer. It's very beneficial to health.
Yeah, I saw that. Is that British study that you're mentioning?
Oh,
Yeah,
well,
okay, very good.
I drink low-carb coffee because I'm sensitive to that. And I drink 4 cups of coffee, and I do it every 2 hours. It helps me stay awake for.
You see, that's.
Today,
Yeah, I mean, so see, that's important what you said. The thing that I tried to mention earlier, and I thought I mentioned it as well, it's important that you decide what is the disturbance of sleep and what is disorder, right? What really works for you. So if you drink coffee and keeps you alert through the day, that's not disturbing. But if it works to you till 11 p.m., it's okay. But as long as you can sleep through the night. So general recommendation is not to drink coffee 4 hours after your wake time. But if you need another, I need one at 1 o'clock today because of this lecture, and probably everybody today. And I'm glad that Dr. Abramson fell asleep, but everybody else was up. But she heard my story before, so she's not amused. Yeah, I think there are cited benefits from drinking coffee 3 to 4 cups a day, and people who add sugar actually have better outcome. That's what the claim is, right? But in Huntington's disease, I would say you have to be judicious about these kind of things, and you have to kind of learn on yourself and work with yourself and apply your own sleep hygiene that works best with your schedule, right?
Right. With
exercise and everything. If you right. That's an individual basis, and I would definitely recommend that you discuss everything with your doctor and work with them and with your caregiver. sometimes it's a good idea to keep the journal, how you sleep, when you take naps, how long you sleep, and you're doing that.
I take 4 naps a day. Okay, I drink a cup of coffee. And
All right.
I take a 20-minute nap. And by the time the caffeine kicks in, my nap is finished, and I'm back, and I can exercise.
Yeah, for the naps, the thing would be to try to keep them as short as possible, you know. If they become longer, then it becomes total disruption of sleep-wake cycle.
No more than 30 minutes.
No more than 30 minutes, yep. Yep.
And so I have to say that I was the great example of the 2 o'clock nap.
There we go. So we have, and we're from same school, I guess, right? So that's why. There's another question here that I think is interesting. A question is melatonin produced in any foods grown naturally, and are the over-the-counter pills created in a lab? Well, I think there are different preparations. There's no standardization of production of melatonin. I really can't tell who is doing what, and I've been like physician for a long period of time. And I saw a couple of cases, not individuals with Huntington's, but general patients, with a couple of cases with toxic liver disease, as a result of herbal preparations. So this is how I learned that how supervised those productions are and not monitored. So I'm very guarded for any herbal preparations or some, food supplements are okay. They are still somewhat regular, but you cannot expect anybody to be responsible to the degree that pharmaceutical companies are. Oh, this says, can exercise help with REM sleep disorder to reduce the screaming and kicking? I'm not, REM sleep behavior disorder is so rare, and Huntington's disease is not most common disorder as well, and then there's very limited research on that. You know what I'm saying? So we're talking about something that we first have to recognize that kind of stuff, and then think about it. It would be interesting to know if that's the case, but we will really need to kind of conduct some. If in an individual case that might be working and be helpful, you are the one who decides if it helps. I don't think we have any studies done on REM behavioral sleep disorder, particularly. There are very few, but they're very small, and we could not extrapolate too much about it. I think that's the most. I apologize if I missed something, but I tried to do respond to all of the questions here. So thank you very much for being so patient and staying awake throughout.